Good afternoon, everyone, and welcome to Race and Trauma, Race-Based Traumatic Stress and Psychological Injury. My name is Jason Jones. I'm a social worker here at the Community Technical Assistance Center of New York, as well as the McSilver Institute for Poverty, Policy, and Research at New York University Silver School of Social Work. I'd like to welcome you all to the webinar and thank you for joining us. And if you're all ready, we'll get started. So I'd like to introduce Robert T. Carter, PhD. He is a professor of psychology and education at Teachers College of Columbia University. His work focuses on white and black racial identity and race-based traumatic stress, which we'll be talking about today. Dr. Carter has published over 75 journal articles and book chapters and authored 7 books. He serves as an expert witness and a legal and organizational consultant. So Dr. Carter, thank you for joining us, and I'll let you take it away.
Thank you for having me, Jason, and thank you, all of you, for participating in my maiden voyage with technology and my first webinar, so I hope it goes well. What I hope to do today is to talk about what the race-based traumatic stress model is, some overview of how we developed the scale and what the scoring for the scale, how the scoring for the scale is done, and to share with you some more recent work that me and my research group have done to try to validate both the instrument and the model. And then lastly, I'm going to touch on some treatment guidelines and issues, and then just cover a few points for conclusion, and then open the floor for questions and answers.
Thank you, Dr. Carter. So we thought that we'd start off with a polling question. So you should see it at the right hand of your screen. And the question is, do you think that racism is a form of trauma? We'll give you a few seconds to answer. A, yes, B, no, or C, you're just unsure at this time. So I'll give you a few seconds to answer before we close the poll. Great. Thank you, everyone, for responding. So our results are 99 of you do believe that racism is a form of trauma. 2 of you don't believe that it is. 2 of you are unsure, and 29 did not answer. And we just wanted to get a baseline for what we're going to talk about today and really everyone's perception of the topic. So thank you for participating. We will have another poll towards the end. And I will say that there is a chat feature at the right hand of your screen as well. If you do have any questions throughout the presentation, please feel free to send those in, and we'll try to answer them as soon as we get them. Thank you.
Should I continue?
Yes, please.
So I want to touch on how I came to this topic. I, as Jason indicated, was concentrating on issues of race and culture by studying racial identity statuses. One of the books I wrote on the topic was the influence of race and racial identity in psychotherapy. And so that was, in the early part of my career, my primary focus. But it turns out that I was asked to be an expert for several race-related cases involving a range of topics early on. And in each of them, I was asked to try to assess whether or not people were harmed by racial encounters. And in my effort to conduct the assessments, I turned to DSM to try to figure out how best to report the psychological harm that I observed in the plaintiffs in the cases. And what I discovered was that the DSM was of little guidance to me in trying to understand racial encounters and how people might have been harmed by them. I found myself having to resort to using generic diagnostic criteria like depression, adjustment disorder, generalized anxiety, and things of that nature. This didn't seem to fit what people experienced, so I was dissatisfied with what I found. And I'll say a little more later about some of the details of that. I also found myself beginning to wonder how was race and racism dealt with in the law, because the cases that I was asked to be involved in were legal in nature. They were about school experiences or biracial custody or racial harassment in various kinds of settings. And so I wanted to try to understand, well, what does the law say about how race and racism should be handled? And when people are harmed by it, what is their course of redress? While trying to figure these things out in I guess, a sort of a not so active way, I also learned through other work that I was doing that people of color were when exposed to potentially stressful events, had higher levels of PTSD than whites, who experienced greater levels of stress as a group, but had lower levels of PTSD. Trauma researchers speculated that the reason for this difference had more to do with white protective status, their social status, and minority social neglect. With this information, I asked if it was possible that racism could be traumatic, and if so, how could the connection be made to events or encounters with racism and psychological and emotional reactions. What's important to understand about this is that what the legal context seems to require is a more specific and direct link from what happens to someone and psychological and emotional harm. It isn't possible in a legal context to contend that someone lived in a context in which racism existed and that, therefore, they were harmed by it. There really does need to be a direct link to the events and the harm the person contends to have experienced. In that sense, then, there needed to be a way to make racism and experiences of racism micro rather than macro, or smaller and more specific rather than large and encompassing. In that way, you could show that the event had an effect on a person's mental health. I gave my first talk about this topic in 2002 that ultimately culminated in a larger paper in 2007 that was published in the Counseling Psychologist. In the 2002 talk, one of the things that I was able to clarify is that one way to make classes of racism more concrete and more micro was to group them as types of experiences or classes of racism. And the classes that were proposed were hostile, avoidant, and later aversive hostile forms of racism. And essentially, these were given specific definitions and shown to be associated or proposed to be associated with various emotional and psychological outcomes. So that was the racism side of trying to figure out how to conceptualize racism experiences in relationship to mental health effects. On the mental health side, I also found myself being dissatisfied with the options in DSM, including PTSD, and therefore thought that what would work better is traumatic stress. There was no way at this time to support these ideas. These were basically theories at the time. So I set out to try to make them more concrete by creating assessment tools for both race-based traumatic stress and for classes of racism. And so, like most good scholars and academics, I started in the literature to try to bring some clarity to how I might go about trying to concretize these ideas. First thing I learned was that the notion that racism is a stressor and that can harm or injure people was not recognized in psychological or psychiatric assessment. It was recognized in the generic psychological literature in which scholars argued that racism was a stressor. What I discovered furthermore is that DSM, therefore, I know there's a 5 out now, don't know if, haven't inspected it as yet. Maybe some of you can tell me whether or not DSM-5 says anything about race or racism. But 4 used the word discrimination once, and of the 52 external stresses, none had anything to do with racial stimuli or referred to racism at all. As I indicated before, I spent some time trying to make sure I understood the literature. So I looked at studies of racial discrimination and race-related stress. And these studies did show that people exposed to these kinds of experiences did experience psychological distress and other psychological and emotional symptoms. But none of the discrimination or race-related stress researchers considered whether or not the stress people experienced would be severe, such that it could be traumatic. And again, remember that if in a legal context, one needs to make an argument about harm to someone or emotional distress, that harm needs to be severe enough to be actionable. If it's minor or not severe, then it won't be considered really actionable. Also, I found that studies of trauma in which researchers who looked at natural events of violence, exposure to war and combat, et cetera, found consistently that people of color had elevated levels of PTSD. Yet there was no consideration in these studies of how racism might be a factor, except one researcher who looked at race-related stress as related to Asian American Vietnam veterans found that race-related stresses were stronger predictors of PTSD than was exposure to combat, rank, or other factors. So this gave me encouragement that there was something to this notion of racism and race-based traumatic stress that currently existed as an idea. When I looked at the measures and assessment tools that were used to assess racial discrimination and traumatic impact, they weren't really very helpful. They weren't helpful for several reasons. Most of the measures focused on primarily Black Americans or African Americans. Most of the evidence about the impact of racism was indirect, that was inferred from high rates of PTSD. So no studies, except the one I mentioned, really looked at racial factors directly. Most of the racial discriminations were developed to assess a range of experiences of racism and discrimination. And therefore, they were not designed to look at a specific event and whether that specific event or encounter was related to a particular set of psychological and emotional reactions. that made them inadequate for the purposes that I was trying to establish. More importantly, while the measures looked at frequency of experiences and some looked at the stress associated with racism and discrimination, none connected specific encounters to a particular set of emotional and psychological reactions, which, again, in the context that I was trying to build this model for, was required. So we still had no way to assess race-based traumatic stress or race-based reactions. So in building the theoretical model or conceptual model, I drew on the work of Carlson, who proposed that traumatic stress could occur as a consequence of emotional pain rather than threat to one's life. That is usually characteristic of PTSD. Moreover, it was proposed that the encounter with racism should be experienced as emotionally painful, but also sudden and uncontrollable to the person. That is, that the person could not control what happened and did not expect it to happen. And that was part of what contributed to the intensity of the pain that they would experience. With PTSD rather, there's a set of criteria, a symptom criteria that one needs to meet. And you kind of check these off, so to speak. I thought that that really was inadequate for understanding race-based experiences, and I proposed that the experiences should have a set of key reactions like intrusion, avoidance, or arousal. At the same time, I thought there would be a cluster, what I call a symptom cluster, that could include anxiety, anger, rage, depression, low self-esteem, shame, guilt, etc., and that the reactions would then reflect a traumatic stress reaction. Lastly, when I first developed the model, I proposed it as a disorder, and later came to the conclusion that this actually should be thought of as an injury. And I talk about my rationale for that in a rejoinder in the 2007 Counseling Psychologist issue, in which I explain that for racial-based encounters, if the race-based traumatic stress was a disorder, it could be argued in court that this was dispositional and not external to the person. On the other hand, if what they experienced was an external insult, so to speak, then they have, by definition, a right to redress, in that this was something that happened to them, not happened inside of them. So one can be harmed and impaired by an external event, and that's what injury captures in a way that I think disorder does not. So race-based traumatic stress is conceptualized as an individual level-based experience that is emotional and psychological in nature, wherein the person must report the encounter as emotionally painful, sudden, and uncontrollable, and have a cluster of symptoms like depression, anger, low self-esteem, and etc., and that the cluster should include two of the core reactions of intrusion, avoidance, or arousal, and should also result in psychological impairment that is clear and measurable. Again, this is still theory, and so it's not been clear whether these encounters that I talk about actually contribute to race-based traumatic stress. And because the assessment instruments in the field did not assess people's experiences directly from their own descriptions of their encounters, it really was hard to determine from existing measures whether or not we could make this connection. So the theory and model that I proposed was built on the idea that people would describe memorable experiences with racism, and then following the description of that experience, report the reactions that they had as a consequence of that particular experience. And so what you see here is the format for the race-based traumatic stress symptom scale. So we start with this open-ended section in which people describe 3 of the most memorable events of racism that they have had, or if they are talking about a particular event that occurred to them, then they can report that. They select the most memorable event of a set of events. They indicate whether or not that event was negative, beyond their control, and sudden, and then they proceed to document reaction by reaction whether or not they had a particular reaction. And they can do that by saying, no, they did not have it, or this reaction was very consistent. In the development of the race-based traumatic stress scale, I'm sorry, let me back up a minute. So the first published article on this topic was in 2009, following the 2007 paper, in which I outlined a assessment procedure. This appeared in the Academy of Psychiatry and the Law Journal, and I was able to use a pool of items that we developed for the cluster symptoms and administer them as an interview protocol in a few cases, and then was able to determine whether or not people had high levels of particular reactions. And then I used that information to come up with the forensic assessment strategy that I reported in this 2009 paper. That helped me then begin to narrow down the elements of a possible instrument. But to empirically verify the instrument, I had to subject the item pool to exploratory factor analysis. And in that exploratory factor analysis, I generated items that covered 10 or 11 different types of reactions that people might have. I think I had 140 items or something to that effect, and was able to administer that to some 380 participants. The structure of the scale I'm going to get to in a minute, but the result of the exploratory factor analysis was published in Psychological Trauma Journal, first online in 2011, and then in the journal itself in 2013, and which it illustrates or shows the exploratory factor analysis results. I only did the analysis on after the event reactions, and I'll explain in a minute what that means. But what I found were 7 factors comprising 52 items, and as you can see, there's depression, intrusion, anger, hypervigilance, physical reactions, low self-esteem, and avoidance. So all the core reactions emerge, plus anger, low self-esteem, and physical reactions. So this particular measure, as published, was introduced as a group-level assessment tool, in which each reaction was followed by 3 questions. And in the first paper, I only reported on the first question, so this is important. So every participant answered, did you have this reaction after the event you selected? Do you have this reaction now as you're recalling the event? Again, here, if events are traumatic, then one of the things that we would expect is some permanence of the memory. The researchers in trauma call it the sort of implant planning the memory such that it reemerges of its own accord, that person has to sort of avoid it, et cetera. And then the third question to each reaction was, did anyone notice any change in your behavior because of your having this reaction? So again, all we did the analysis in the exploratory factor analysis was on the first question, did you have the after the event question. But we needed to also know whether or not the after event responses were related to the now responses. If they were not, then the theory goes out the window. We also needed to know whether people who said, I found this event painful, sudden, and out of my control, did they tend to report that item more often than people who didn't say that. So to answer that question, we created a canonical correlation analysis on the 380 participants that we did the exploratory factor analysis on. And the canonical correlation just allows you to have multiple independent and multiple dependent variables and to see if they come together in a significant or meaningful way. And what we found in the canonical correlation by looking at after and now for the same participants was that, yes, the reaction scales came together empirically in the canonical correlation analysis very consistently. This table illustrates some of the numbers, but I won't stay here very long. Well, what happened was that intrusion after the event and intrusion now were connected to one another. And avoidance after the event and avoidance now were connected to one another, such that this is showing that the after and now reactions were related to one another empirically. But we had another problem. Because this was group level, this would not have clinical significance. So we needed a scoring strategy that had clinical meaningfulness. And we had to have a way for the scores, when you look at them, to have clear meaning and that were easy to interpret. The result that I just shared with you was published in Traumatology in 2014 online. I don't know if it's appeared in the journal yet, but this is the study that looks at the canonical correlation findings, that introduces the scoring procedure, and that looks at the did your behavior change? So to come up with a person-level scoring procedure, we propose that sample means and standard deviations be used to convert individual participant scale scores to Z-scores and to then convert Z-scores to T-scores. What that means basically is that T-scores have a mean of 50 and a standard deviation of 10. And in a moment you'll see what that might mean. So here you can see raw scores, conversion to Z-scores, and then the Z converted to T. And if you look at the T-scores, you'll see that the scores range from 40 to 60, or 61 in this instance. So when you look at the scores, you can tell immediately that they're below the mean, at the mean, or above the mean. So by seeing that depression and anger for this person are a standard deviation above the mean is particularly meaningful. The clinician or the researcher can now interpret the meaningfulness of this score. And you can assess the extent to which people who you're assessing are exhibiting race-based traumatic stress reactions or not. You can also see that intrusion is just almost and hypervigilance about a half a standard deviation above the mean. So something is occurring in this score configuration, if you will, that allows you then to interpret the meaningfulness of it. Excuse me. I'm not going to go into a lot of depth and detail with the statistical analyses for the validity evidence. But what I will say is that we established and created an instrument, and we established some initial construct validity for the instrument and the results of the exploratory factor analysis. But we needed to do further work to be able to replicate the findings on a different sample and to be able to subject that sample data to a different set of analysis that confirm, or what we say validates, the constructs and the concepts. To do that, we used exploratory factor analysis, and we used structural equation modeling. And we did it on a sample of 600, almost 620 adult community participants and some university participants. Majority of the participants were community-based people in the Northeast, and we used a varied racial sample. So all of the studies that we've conducted so far have had multiracial samples. I think that's important, and I'm not going to talk about that, but I suspect someone will ask me about it, and we could talk about it. In the confirmatory factor analysis, there are two steps. One, can you replicate the results that you have? Can you show that the items actually relate to these constructs? And what structural equation modeling allows you to do is to test that without directly measuring the construct. So depression, anger, hypervigilance, and avoidance are constructs indicated by the items that were made up that made up the scales. If you can find, using several indices, that there's a good model fit, then that model fit says that you have confirmed the existence of both the construct and the items that make up the construct. And we have been able to do that in a first-order confirmatory factor analytic study. And in that study, we asked the second question, which is the second-order structural equation modeling, where we asked whether the constructs based on the scales that represent the scales would predict or be related to a construct called race-based traumatic stress, and can we find evidence to support that? That is, model fit information that says, yes, this model is a good fit to the data. And the answer to the question is, yes, we found that. Lastly, we use the scales to predict psychological distress and psychological well-being, and we've had some partial support for those relationships. We then went further and asked whether or not we could confirm a model for just Black participants only, and would the second-order question be answered for Blacks only. And I'm happy to report that we just recently completed that manuscript, and we found model fit for both the first and second-order model. So again, the constructs work both for a multiracial sample and for Blacks only. And our regression analyses in that study also seem to confirm the relationship between race-based traumatic stress scales and psychological distress and psychological well-being. And lastly, we explored whether or not classes of racism could be established empirically. This is a little more complicated because this required that we take experiences of racism and see if we could group them through exploratory factor analysis into 3 classes of racism. And we needed to do that before frequency of experience and stress reactions to the experience separately. Again, I'm happy to go into more detail about these, but what I can say is that, yes, we found classes of racism for frequency of experience as well as for stress reactions to the experience. And then we proceeded to try to confirm that on a different sample and found that the items that made up classes of racism for frequency and experience were, in fact, confirmed in the confirmatory factor analysis. and then we used the classes of racism to predict race-based traumatic stress reactions. And again, we were successful in being able to do that, such that avoidant reactions were, such that the stress of reactions were stronger predictors of race-based traumatic stress reactions than were frequency, and that hostile racism and aversive hostile racism tended to be related to more race-based traumatic stress reactions than was hostile racism. Now, I thought at one time hostile racism would have more race-based traumatic stress reactions, and it didn't turn out that way. It was avoidance and aversive hostile racism. And it seems that when people's experiences are more ambiguous, then there's a stronger race-based traumatic stress set of reactions to ambiguous experiences. If someone's being hostile towards you, you kind of get that. So if you're being stopped or you're being followed in the store, you kind of know what's going on. But when you have those experiences in which you're asking yourself, what just happened? And is that really about race? Then the potential for traumatic stress seems to be greater. So this slide sort of talks more about the specific predictive validity evidence for classes of racism that I just went over. So as you can see, stress was related to 4 of the 7 race-based traumatic stress scales, while hostile racism was related to 3 and avoidant was related to 7 of the race-based traumatic stress symptoms. And so this variation in reactions to classes of racism does indicate that empirically that there's something happening that's important with respect to the measures and with respect to the reactions that are associated with the types of experiences that people might have.
Great. Thank you, Dr. Carter. So we'd like to take this time to really ask you another polling question. And again, you will see it on the right-hand side of your screen. So how comfortable do you feel speaking with participants about race-related issues? A, very comfortable. B, somewhat comfortable. C, unsure. D, uncomfortable. And E, very uncomfortable. Again, we'll give you a few seconds to participate, and then we'll release the results. Thank you for participating, everyone. We're just going to give you a few more seconds to get the results. Great. So it seems that the majority of you are either very or somewhat comfortable about talking about race. And if you could chat in, I'd love to know why that is and how you built that comfort, because we found that many clinicians are very uncomfortable with that subject matter. So if you could chat in anything, any kind of training that you had or anything that you say to participants, please let us know. And we also do have a chat question here. So what concerns do you have regarding speaking to participants about race and race-related issues? So if you do have any concerns, please let us know, but also please let us know what you do talk about in these instances.
Yeah, I would like to say this means that you're going beyond the are you comfortable dealing with us because we're racially different. And it goes beyond the superficial conversations about race.
Thank you for all of you for participating. I'm getting a few things in now. One participant has said that you've attended the Undoing Racism workshop, and you continue to talk with your colleagues and like-minded friends and attend workshops and seminars to help learn how to have these deeper level conversations that Dr. Carter was just referring to. Leah said, I talk about recognizing that race and race-related issues can be difficult to discuss, and getting that out of the way makes it more open and honest, makes it a more open and honest space. Thank you. Teresa said, I am an African-American clinician, so I suspect I am more aware of race-based issues. And that's an interesting comment. I'd love for you to expand on that if you have time, Teresa. Thank you. Also, another resource from IDA is the Race Forward conference that really helps you deal with these types of multicultural issues. Great. I'll just highlight one more, and please continue to chat in, and we'll definitely have these as resources for everyone. Malwina said, as a white person, I think developing my own racial identity has helped me be more, sorry about that. As a white person, I think developing my own racial identity has helped me be more able to discuss race and made me realize that I previously moved through the world as though I didn't have a racial identity. Thank you. Please keep chiming in, and we'll be sure to highlight some of your comments. Dr. Carter, feel free to continue when you're ready.
Thank you. So contrary to what some of the participants are reporting, most mental health professionals have difficulty with racial issues. And they typically do not directly discuss experiences with racism. And this has been reported in a couple of studies in which clinicians and clients or potential clients clients talk about the fact that they don't bring these topics to clinicians because they don't feel like clinicians have the training or wherewithal to deal with them. More often than not, clinicians are not trained in their primary training programs to handle those issues, and more often than not, a handful do, but some do not seek training for grappling with the significance of racial issues or experiences. And one of the things that I'd like to do is distinguish between race and multicultural issues. I operate in a program that considers itself to be multiculturally aware and incorporates lots of multicultural issues into its curriculum, but race doesn't tend to get the same level of focus and treatment. And I have argued that race is a distinctly different set of experiences than is subsumed under the sort of multicultural rubric. But just to repeat, clinicians tend not to seek out training, so those of you who've said that you have done so, I congratulate you for that effort, but most don't, and many programs that train clinicians, regardless of the level that you train at, don't know to generally integrate this throughout the training experience. And clients will withhold this information from mental health professionals as well. So there's a sort of a dual process occurring in which clients don't bring it up and many clinicians are not taught to deal with these kinds of issues. I think that it's important that the person who tries to deal with these issues that sees and understands how race might influence the participant and his or her own development and behavior as a therapist. Many times there's a one-way focus on issues of race in training and or in post-degree training, in which we talk about how we need to engage the client around that. And there tends to be somewhat less focus on the therapist developing an awareness of themselves as a racial cultural being. I contend that it's critically important that first the clinician understands him or herself as a racial cultural being, to understand how race influences them, and then they can engage the issue potentially with their clients. It's important to learn about the participants' life circumstances, background, and ways of responding to their environment as it involves race. A lot of us really tend to miss the importance and significance of racial issues or the depth of them. And sometimes people are taught to discount the racial issues and see the issues as something that has to do with the intrapsychic issues that the person has operating. And as a consequence, they typically change the topic. I suggest that there be some effort to build a racial cultural history of the person by asking about how the client and his or her family and others currently and previously identified racially. And again, this is complicated because race and ethnicity are often fused and merged and are treated one for the other. And sometimes this is accurate and sometimes it's not. Learning about whether or not there has been any difficulty in the person's life as a consequence of race, whether they've found themselves humiliated or they take pride or strength in their race is an important aspect of the assessment process. If Christians try to do this, then it should be their objective to contextualize the issues, to see them in a larger context of society rather than just as intrapsychic. The person should have some understanding of racism as it is embedded in U.S. society and culture. This tends to sometimes be hidden and an undercurrent in our society, and at other times, like currently in current affairs, it tends to be much more obvious and explicit. It seems to be exploding all over the place these days, and one can only speculate about what that is. It just seems to support the argument for some of us that race is a continuing factor in our society that has lots of significance. It's also important to understand how the racial encounters that a person has may be associated with their presenting concerns. Our focus as mental health professionals tends to be on presenting concerns and focusing on the person in front of us when and we can lose sight of the fact that there are other factors that may be exacerbating, influencing, be hidden by the presenting concern. And it can take some careful digging to discover that. Lastly, the composition of the racial dyad and the power differential is also important. I think of race not as skin color and physical features. I don't think of race identity as one saying I'm white or I'm black or I'm Native American, but rather that you understand the psychological variation in your understanding of yourself as a racial being. So that's what psychologically based racial identity represents, and it applies to members of all racial groups. That's kind of what I think is important to take into account when you're thinking about racial composition. I argue in the book that I talked about the influence of race and racial identity in psychotherapy, that what's important is not the visible skin color of the participants or the visible race of the participants, but it is how they understand themselves as racial beings that matter more than anything else. And this psychological complexity sometimes is not integrated into how we understand the role of race in therapeutic encounters. So one of the things that I've talked about in terms of traumatic stress or race-based traumatic stress are the reactions that a person can have as a consequence of a racial encounter. So therefore, therapists should keep in mind what kinds of reactions or symptoms that a person may have as a consequence of racial encounters. To the extent that they have some, then the clinician might want to focus on the post-event symptoms and try to help them reframe the aversive out-group feelings that they may have to the extent that this occurred with an out-group member. It could be an in-group member. That's also possible. You want to try to work on the in-group, the effect on the person's identity, and try to diminish as much as you can the avoidant behaviors that may emerge. What gets impacted more than anything else by racial issues is the assault on the sense of self or sense of self-worth. And clinicians should be very sensitive to trying to rebuild this sense of self. In part, the damage to the sense of self occurs because of the inexplicable nature of these kinds of experiences. And the inexplicable nature of the experiences increases the intensity of the insult and wound that the person experiences. It also makes it harder to talk about. It's extremely difficult to talk about something that's inexplicable. Oftentimes, clients will say, if you inquire more deeply about their racial experiences, then no one ever asked them about this. So trying to get at the details and specifics of their experiences might be helpful, or you might run into resistance. What's tricky about dealing with race and racism in treatment is that it renders what we consider to be our primary objective superfluous, because both the client and the therapist are helpless in this matter. And I think it's hard for therapists to be helpless, to be rendered unable to help their clients with respect to what they're bringing to them. And my suspicion is that clinicians avoid this sense of helplessness that they may encounter in dealing with issues of race. This is something that at some level, at least initially, you really cannot help the person with or help them understand it or bring clarity to it. So all the things that we value as clinicians that we seek to accomplish in our work with clients fall away and aren't really useful to us. And it puts us in a position where we have to accept that we really can't do anything about what happened to the client. We have to simply accept how they've been affected and how they feel about it and how it affects them. We have to come to terms with the reality that there is nothing like racial trauma. Other forms of trauma, I think we could give some meaning to. We can help the person get what it's like to be shot at or to be beaten, et cetera. But to be targeted and treated in a hostile, humiliating way simply because of your race that has nothing to do with who you are as a human being, there's no way that you can rationalize or empathize or make them feel better, nor can you make the pain go away. When we get seduced in trying to make the client feel better, then we begin to move into an area where we could potentially be causing more harm than being helpful. So there's this both and quality to the client's emotional experience. She or she can be bewildered, in a state of disbelief with a mixed range of feelings and reactions. And at the same time, the person can have their emotions and cognition all interconnected and difficult to tease out. A lot of times, so for instance, if we use cognitive behavioral strategies, we will try to sort out, what the thoughts are and what the behaviors are, and try to make sense of them that way. But in this instance, those are activities that may fail because everything is intertwined and interconnected and hard to tease out. So, race-based traumatic stress injury, I'm arguing, is not a form of trauma that is like PTSD. PTSD is distinct. I'm proposing it as a non-pathological injury. I have been able to document to move from theory to empirical support. So I feel significantly more confident that what I'm describing and what I'm reporting is quite real and has been empirically verified. Now, I thought it was real before when I developed the theory, but it's gratifying to have empirical validation. It's important to know that the elements of the scale are related to one another, so I feel good about that, and that we've moved from a group level to an individual level scoring approach that can be beneficial to individual clinicians as well as to researchers. So you can determine what portion of a sample, for instance, shows elevations in race-based traumatic stress reactions and the portion that does not. The validity evidence that we've established has been done with both multiracial groups as well as Black only, and we've been able to show empirically that the classes of racism notion as merit both in terms of frequency and stress, and that there is meat to the theory of race-based traumatic stress injury. And it's my hope that you all, as practitioners, scholars, researchers, can make use of these ideas in the course of your practice. Thank you.
Thank you, Dr. Carter, for all of that incredible information, going through the assessment with us, and really just engaging with the topic. We will be transitioning to the Q&A portion of the presentation, and thank you all, everyone, for sending in such great questions. Dr. Carter, if you're ready, I'll start fielding you questions, and we'll go from there.
Sure.
Okay. One participant asked, well, they stated, I have done work with a lot of terminally ill clients where they are in a situation where there is nothing you can do except be present and be a witness. Would you say that's a useful framework to work with racial insults?
It's an intriguing question. I'm not sure whether that's the framework. My thought off the top of my head, and I really feel like I should think about this because it's a good question, is that unlike the terminally ill, the person is going to have to continue moving through life. I think there's some part of the process that will involve sitting with them because you can't really do anything. But at the same time, there comes a point, I think, when it's possible to talk about, so what do we do? And what do you do if you encounter this again? Or how can you reframe it or cope with it better? So there does come a point, I think, when you work with people when you are able to talk about this at a deeper level, where you can actually begin to play around with some approaches and strategies.
Great, thank you. Another question is the race-based traumatic stress scale available for clinician use, and if so, how do you get trained in it?
The articles that I've indicated tell you what you need to know to administer and score it. So the psychological trauma 2013, the scale is published there and the items. And then the traumatology article, it shows you how to do the scoring. But if you want more training about how to use it, then I would be happy to help anyone with that.
Great, thank you. Okay, what types of questions would you suggest asking to make sure a clinician fully assesses the impact of race on a client they are treating?
Again, in the 2009 article in the Academy of Psychiatry in the Law Journal, I have an outline of a set of questions that should be used for the racial cultural assessment. I'm not sure if that's exhaustive, but that's a good resource for that. And again, this is another thing that I would be happy to talk to someone about if they wanted more detail.
Great. We do have a question about the DSM. So one participant said, Dr. Carter, you mentioned that the DSM and other clinical guides fail to capture the impact of racism as a stressor. However, you mentioned that there have been discussions of racism's impact within scholarly literature. Why do you believe that there is no inclusion in the DSM and other guides despite ongoing research, including your own, demonstrating a link between trauma and racism?
I think it's complicated on multiple levels. So the group that handles DSM are psychiatrists primarily, not psychologists. They tend to operate in a different world than do psychologists, so I don't know that they're privy to the psychological research that's emerging. Some of it's beginning to penetrate the health psychology area or the health area. But I don't know that they're aware of what we're doing in the psychological area. And I also think there's sort of disagreement or controversy about what racism means, how to assess it, and things of that nature. And lastly, if I were asked, I would not want to see racism in the DSM, because DSM is the Diagnostic and Statistical Manual of Mental Disorders. I'd rather see it documented in legal cases in which people are able to seek redress for it. So I don't want it hijacked by the notion that this is a dispositional matter rather than it being an actionable matter. So I think that's some of the complexity associated why you may not see it in DSM.
Great, thank you. One participant asked, do you think this could be replicated for LGBTQ communities?
I have no idea. I think that discrimination is similar, but racial discrimination is distinct. But I don't know.
Okay, great. And to that end, one participant asks, is the scale used for various populations, or is it just used for Black populations?
All the samples that we've done research on have been multiracial. They've included whites, Blacks, Asians, Native Americans, and biracial people. And we found no differences between the groups in the studies we've conducted with respect to race-based traumatic stress responses, both at the item level or at the scale level.
Great. So one participant says that there are some similarities between raising questions about religion and spirituality with clients as with race and racism. As clinicians, we do not want to appear to be imposing our values upon our clients. Might race and racism as a values perspective function in a similar way and thus a penchant of avoidance?
Possibly, except that sometimes we can't see people's religion or spiritual beliefs when they walk in the room, or we can see their race. So race operates in a different kind of way, and the society kind of operates on this principle of religious freedom, and that's not been true with race. And so I think there's some similarities, but also some important differences.
Great, thank you. One participant asks, can you talk about the difficulty that clinicians face when talking about race? What feeds into that, and especially between a white clinician and a participant of color?
I think that there's a tendency in our training programs to teach clinicians about mental health practice as if they were not individual people. I think this is also true of other kinds of professionals. We have a cultural practice of trying to separate who we are as people from who we are as professionals. And so I think that cultural practice feeds into this notion of separation, and therefore we don't integrate in the training how to help the person become more aware of themselves as a racial cultural being, and for them to look at what they bring to the training as a person in terms of how they understand themselves in that context. That, I think, is a major contributing factor to how come they would have difficulty, or clinicians sometimes have difficulty dealing with these sort of issues that clients bring in, because they're there as a person. So they don't have the sort of dual, the dichotomy between themselves as a person and as a professional. Those of us who are professionals operating in the mental health world, I think, have that dichotomy that operates and potentially can get in the way. Makes it uncomfortable. When I teach students about this in classes that I teach about race and culture, they're exceedingly uncomfortable talking about themselves as racial beings and talking about themselves as racial beings with other people, regardless of the race of the other participants. So it's building that comfort level, I think, is an important component to helping people be more comfortable with dealing with issues of race, both as people and as professionals. And I think if we can merge that more, we'd be more successful.
Thank you for that. The next question that I have is from a participant that says, if part of the problem is that clients have no recourse when injured in this manner, do you think there may be a reduction in race-based traumatic stress as more perpetrators are held accountable for their injurious actions?
That's my hope and wish, that most avenues to racial inequality, to redress racial inequality, have basically been shut down over the last 15 or 20 years. So when you have nowhere to go or nothing you can do when people do stuff to you, then it does exacerbate, I think, the injury or pain that you experience. If that can be opened up with race-based traumatic stress injury as something actionable for individuals and groups, then I think that could begin to open up some of the, reduce some of the impact once people are aware that there's something they can do. The difficulty is getting this through our court system and getting lawyers and judges and people in general to see this as something that is important and valuable. So I'm hopeful.
Great, thank you. And thank you, everyone, for continuing to submit questions. Thank you, Dr. Carter, for answering them. We do have a few more here. So one participant says they have a question regarding the action being sudden. At some level, most people of color born or raised or living in the United States expect to encounter racism, as evidenced by racial socialization processes. Will you reconcile the processes of racial socialization as preparatory or protective measures with the idea that racial incidents are sudden and or unexpected?
So I thought that too when I started working in this, and yet while we kind of know it's out there and people have some awareness of it, some people do, depending upon their level of awareness of themselves as racial beings, yet what I've come to is that when it actually happens to you, you don't expect it. You just don't expect it. So I remember vividly once going into a store to buy something and being followed by one of the store personnel, and the last thing I expected was to have that happen to me. And there it was. And so the reality of it, so it's one thing to kind of be generically prepared or to be kind of have an alert on. It's another thing to encounter it directly. So more often than not, when it actually happens to you and it's clear to you what it is, that's what makes it sudden.
Great, thank you. The next question that we do have is, can you talk a little bit about the impact of national race issues, i.e. Trayvon Martin, Eric Gardner, Michael Brown, on the therapeutic relationship in regards to race-based traumatic stress?
I could try. I'm not sure how. This is very. It would really matter in terms of how the person understands those issues in terms of his or her life. So it would be hard for me to speculate how to integrate that into the work with an individual person. There's such a large number of these events that are occurring that my guess is that it sort of it has a kind of vicarious effect, but at the same time, it's hard for me to know how it might affect an individual person's psychological health.
Great, thank you. Another question that we do have is, how might the experience of racism be distinguished from other forms of the impact of violence on race-based traumatic stress injury?
What is there any example of what they mean by other kinds of violence?
No, unfortunately not.
Okay. I think that there's, in our country, there's a very long and complicated and well-documented history of racism, and that it is very specific and distinct. So while other forms of violence do exist and affect people and could create for them PTSD reactions, I think the reactions associated with race and racial encounters are distinctive, and I don't know if they cross over or interact. One of the things that I've tried to do in my research was to locate portions of to have participants who have had little or no prior racial experiences who report some, to have people who have had other traumatic experiences and then report race-based encounters, and then others who have had, I'm blanking, I'm sorry. But to look at groups in terms of those kinds of distinctions, so people who have had little racial experiences, who only have had racial experiences, or people with other traumas and racial experiences, to see how they vary or what are the factors that affect how they respond. But I'm still trying to collect and gather data.
Great, thank you. So it seems as if that's also ongoing.
Yes.
The next question that I have is, do you have any recommendations for treating participants whose depression or mental health symptoms are actually quite a normal response to ongoing issues of racism, power, and privilege?
I think it's important to normalize it. I mean, it's one thing to become depressed by them. I don't know that typically we don't think of depression as a normal response. So we don't usually say, well, that makes sense that you'd be depressed about that, particularly those kinds of experiences. So when we do that, we all often think of these things as sort of passing, transient kinds of experiences that might cause someone to be depressed for a time, but then we expect them to come out of it. Again, our cultural practices kind of get in our way because we kind of expect people to get over it, to move on. So that's a very high expectation in our society. We don't typically say to people, oh, you've been depressed about this for a year. Oh, okay, that makes sense. So, let's see how we can at least get you to be minimally functional or something. We don't kind of accept that as a okay response or reaction. I would encourage normalization of those kinds of reactions.
Great, thank you. I do have a very interesting question and concept that just came in, and I'll paraphrase if I may. One participant discusses the race as a social construct, and being a first-generation person to come to this country, race and racism wasn't discussed in their family. And they want to know, does your research address the variable of the infused idea of race and ethnicity and the differences that many people in this country may have about it?
I don't know that my research does that or focuses on that. My understanding of this is that, so let me back up. So lots of people have come to this country from other places for many generations. So this includes Europeans who came, it includes other people of color, Asians, et cetera. It includes people from the Caribbean. What's true about their experiences is regardless of what they believe to be true about race before they got here, what they knew about it, they come to be taught how we do race in the United States. And how race is dealt with in this country is distinctly different from how it's dealt with anywhere else in the world. And you either get with the program or you then are treated as a member of the dominant group or the non-dominant group, your call. So I think it's important for people to understand the societal indoctrination into how we do race in North America.
Thank you for that incredible answer. The next question that we do have is from a participant who says, I wonder how much trauma, as traditionally understood, along with race-based traumatic stress, is the lived experience of African Americans. Is there such data about this?
Is the lived experience? I'm sorry, I didn't. Could you repeat that?
Sure. They said that they want to know how much trauma, as traditionally understood, along with race-based traumatic stress, is actually the lived experience of African Americans, and if there's any data on that.
How much trauma? I don't know the answer to that. That sounds like, is there a way to assess the intergenerational transmission of the trauma of race? And I haven't got there yet. So the empirical research work on race-based traumatic stress is very early, recent. So we haven't got to the intergenerational effects as of yet. So there's some work on Native Americans on the intergenerational transmission of what they call cultural trauma. So there is evidence about that, and it's pretty good evidence. And that's an area that really could use some additional researchers to pursue. I suspect there's quite a lot of intergenerational trauma for Black Americans.
Great, thank you. The next question that we do have is, does your model incorporate the socioeconomic consequences of racism and their relationship to trauma in the lives of people of color?
I don't distinguish SES at all. What we've been doing is trying to sample broadly, so I don't focus on that. I also think that I don't focus on it for another reason, because I think SES and race are confounded, and so I have difficulty separating them out. When systems of oppression have been designed in such a way as to keep people at a low social status and therefore consequently a low socioeconomic status, it's hard for me to separate out the socioeconomic issues from the racial issues. I think they're intertwined, and I cringe when people act like they're not. So I don't think it needs special focus. I think it's pretty obvious when for centuries, people of African descent and people who were born here were held into a caste system and prevented from any kind of movement out of that system. I think it's pretty clear that race was used to maintain them at a low social status. And it continues to be true. That's what we were seeing in Baltimore.
Great, thank you. Another question is specific to the variables used within your work. The question is, can you discuss the usefulness of the variables that you use, such as intrusion or hypervigilance, and why you selected these variables?
Some of them had to do with evidence of traumatic reaction, so that one of the characteristics of having a trauma versus just being stressed was a presence of, let's take intrusion, of reoccurrence of the particular event, of that intruding on the person's consciousness, of them becoming overly anxious, of them monitoring their environments as a consequence of what happened to them. So these are elements or aspects of traumatic experiences that I thought needed to be included in to meet the criteria for trauma.
Great, thank you. I think we have time for about 2 more questions. One participant would like to know, how might we contact you or follow up with you regarding your race-based traumatic stress research?
At Teachers College, Columbia University, I can be reached there. I have an email address, if that would help.
Okay, great. And I think that's actually included at the end of the presentation. So I think that everyone should be able to see that as well. The last question that we do have coming in is, do you think that race-based traumatic stress could be another catalyst to shift thinking about trauma from more predominantly being understood when it meets the criteria for PTSD to broadening it? And the participant goes on to say, it seems that many items and experiences that are identified for PTSD are also injuries, not simply deficiencies in the individual.
I'm sorry, Jason, I got distracted. I apologize. What did you say?
Well, the question was, do you think that race-based traumatic stress could be another catalyst to shift thinking about trauma?
I don't know. I'm really not. I guess I'm not trying to shift thinking about trauma as much as I'm trying to understand how people are affected by racial experiences. So I'm not really, trauma is not, I got into trauma because that's sort of where the work led me. Not so much trying to get our understanding about trauma shifted.
Great, thank you. Thank you to everyone for participating. I would like to bring us to a close. Dr. Carter, I'd like to thank you so much for the work that you've done, for presenting it here to us, and for really engaging in this discussion with us. It has been extremely helpful. Yeah. I would like to say that we do reference a lot of Dr. Carter's work. The references are here. If you'd like them, as he said, you can find the scale and how to use the scale in his work. So please, if you can, download that and really make use of it. We do also want to note that, so this is a collaboration between the Community Technical Assistance Center of New York as well as the McSilver Institute here at the New York University Silver School of Social Work. And McSilver actually just published a report on April 27th called Facts Matter, Black Lives Matter, the Trauma of Racism. And it's really broadening the discussion of how racism and trauma are not only related, but that racism is a form of trauma. And we would like you to view that report if you can. It's at www.mcsilver.org. You can simply download it and make use of it as well. We would like to note that there is an upcoming webinar that is very similar to this topic. It's called The Role of Racial Trauma in Psychotherapy, presented by Monica T. Williams. There will be a CEU for this, simply a $15 processing fee. But the webinar will really talk about the role of the clinician within the therapeutic space when it comes to talking about racial trauma, things that you can say, what you can do, much of what Dr. Carter was discussing and many of the questions that he answered, and just her specific experiences with that. That will be on July 23rd. We will be sending out an announcement, so we hope that you can all join us for that as well. So again, if you do have questions about the presentation, any of the materials, please feel free to contact me at jason.jones@nyu.edu. We're very gracious to Dr. Carter for offering his contact information specifically to his research. Many of you did have that question, so please feel free to contact him for more clarification. His email address is noted here. And again, thank you all for participating. Thank you, Dr. Carter, so much for all that you've said. I would say that all of the information that is here today was recorded, and it will be on our website at ctacny.com. I have also noted all of the resources that you've provided us with, so I will make a resource list and provide everyone that was on this webinar as well as the wider CTAC community with that resource list. So again, thank you, and we hope that you have a great day.
Thank you.
Bye.